What's up, everybody? Dr. Rossi, Shrinks and Sneakers, and it's been a minute since I've been able to really sit down and work on my YouTube channel, but I'm excited to be back and working on it. And one of the first things that I want to go over is a new series that I'm going to be doing. It's called Case Files from the Ward. And we're going to be going over real life scenarios from my clinical practice where I can point out the clinical pearls, but also some of the blunders that I see in psychiatric management and teach you guys, either as the person who's going through treatment or the person providing treatment, how to do a better job and where there's room for improvement and where things also go well. So I'm extremely excited to bring this new series to you guys, and if I've ever been helpful to you in the past or I'm helpful to you now, I'd love for you to hit the like button and also subscribe to the channel. It really helps me to know that you guys are getting value from the content that we are creating. So in the first episode, Case Files from the Ward, I want to go over the OCD nightmare, because this was a real case that I had, and it opened my eyes up to some of the places where people don't understand OCD. So I want you to take a second and I want you to imagine that you have debilitating OCD for years. Maybe you were even diagnosed with OCD at a young age as a child adolescent patient, and you're getting prescribed a cocktail of medications that not only don't help, but actually make things worse. And that's exactly what happened in this case. So this is the kind of mismanagement that gets people hospitalized, and I want to break it down for you here in this video. For those of you that are subscribers to the channel, then you know that I am Dr. Garrett Rossi, and I want to welcome not only you guys who have been loyal subscribers to the channel for years, but also those who are new to the channel and learning about psychiatry maybe for the first time. This series is going to be called Case Files from the Ward, and I'm going to take you inside real psychiatric cases. I'm going to bring the real-world clinical scenarios to you, the viewer. And today what we're going to be talking about is OCD, so obsessive compulsive disorder. And not the quirky kind you see on TV shows or reality shows or maybe even on TikTok or other social media platforms, but the real kind of OCD that wreaks havoc in people's lives and might even land people in the hospital. Why don't we start with a case summary, because you guys need to understand the clinical scenario and we need to set the tone here. So imagine a patient with long-standing OCD is admitted to your service for severe anxiety and suicidal ideation. Now, many times patients come to the inpatient unit with OCD not because of the OCD directly, but usually because there's a behavioral problem or there's suicidal ideation or a suicide attempt. So this was one of those cases where suicidal ideation was the prominent issue, resulting in hospitalization. Now, one thing you might be thinking right off the bat is, Dr. Rossi, what medications was this person on, or what treatment were they receiving? Now, of course, I want to say that psychotherapy is very effective for OCD, and I don't want to undermine it. But when you're in an inpatient scenario, you're often thinking about medication management. So the med list for this disaster ended up being paroxetine, 20 milligrams daily, Lamotrigine, 25 milligrams daily, of course, alprazolam, also known as Xanax, 1 milligram TID, and the second generation antipsychotic or dopamine blocking medication, or Olanzapine, 10 milligrams at bedtime. Now, to me, right off the bat, none of these made any clinical sense for OCD. So I'm going to break down in the next section the clinical errors here and how that management could be improved. All right, guys, so let's dissect the clinical errors in this case because there are many. Let's start with OCD management, right? The primary issue that I identified in this case was OCD. It was driving the anxiety and it was driving the suicidality. So that was our primary issue that we were attempting to improve. Now, that particular form of OCD was coming in the form of contamination-based OCD, and quite honestly, as you can see from the medication list, it really wasn't treated at all. The paroxetine was significantly underdosed, and while it's not my go-to SSRI for OCD, the real problem is that it was never titrated to a maximum dose and never held for 12 weeks at that dose. Now, I personally prefer the medications sertraline or fluoxetine as first-line options in OCD, and more often than not, people need higher doses. So you may need to get up to 80 milligrams of fluoxetine or 200 milligrams of sertraline, for example. And in some clinical cases, you even have to go above the FDA-approved maximum. For example, fluoxetine up to 120 milligrams per day, or sertraline up to 400 milligrams per day. Let's take a second to talk about the benzo trap here, because this was a significant problem in this particular case, and it's one that I would say is not uncommon in psychiatric practice in general. Somebody has really bad anxiety. We really didn't create that diagnostic hierarchy where we're determining what is the driving force behind the anxiety, and the person unfortunately ends up on something like a benzodiazepine, specifically a very high potency, short-acting benzodiazepine like alprazolam. So in this case, the patient had been on 3 milligrams of alprazolam daily for over 2 years, prescribed by a primary care doctor. And I don't really fault our primary care colleagues necessarily, but I do wish that they talked more with us. I wish there was more education available. That has always been one of my goals. So I don't want to get too far off the topic. So let's just say he was on 3 milligrams of alprazolam. By the time I saw this individual, they'd already been off the medication for 5 days. Now, they weren't coping all that well with coming off the medication, but they also didn't have acute physical symptoms of withdrawal, such as elevated heart rate and elevated blood pressure, and they were able to tolerate it. Now, if I were doing this taper from the beginning, ideally I would switch the person to a long-acting benzodiazepine and taper slowly, because that's what you're supposed to do when you're a good psychiatrist, right? But at that point, I felt like there was no point in putting the toothpaste back into the tube. In my clinical experience, when we try to stuff that toothpaste back in the tube, it gets messy and things often get worse. And you also have to take into account in this case the recent suicidality. Restarting a short-acting benzo doesn't seem like a good option for this individual, so we decided not to do that and opted to treat, again, the OCD as the primary issue. Let's talk about where Olanzapine fits in this treatment. Now, this, in my opinion, was a big mistake, and here's why. Augmentation makes no sense before the person has had a full trial of SSRI medication. So before you've done that sertraline, fluoxetine, whatever medication you choose, you really don't want to add augmentation strategies. It doesn't make sense to add these medications because you haven't had an adequate trial yet to prove that the person either didn't have full remission or didn't even have a response. Even worse, people forget Olanzapine and clozapine are 2 medications that actually worsen OCD. They make people with obsessive compulsive disorder worse. So if you need an augmentation agent here, like let's say you've gotten to the maximum dose of paroxetine, they've been on it for 12 weeks, they've had a response, but they haven't achieved remission, you may consider a medication like aripiprazole. This has direct randomized controlled trial evidence, and it actually beat quetiapine in a head-to-head trial for OCD. Now we need to talk about Lamotrigine, because in my mind, this was a stretch from the beginning at best. If you look at the evidence for Lamotrigine in OCD, what you will find is that there is one small randomized controlled trial that suggests some benefit for OCD, but this patient never even got to the first-line treatment. Again, that's my main point. So Lamotrigine isn't where you would start. It probably isn't where you would go first line, second line, third line. It's probably much further down the list for me. And because of its limited evidence, we don't even really know if it has any effect on OCD. Like I said, there's a 16-week trial that showed it was better than placebo when added to a treatment, an existing treatment, such as paroxetine. So I want to wrap the video here, guys, and I think that what this particular case points out is that this is what happens when psychopharmacology is sloppy. So if you're going to be a psychopharmacologist, try to be a good one, right? Try not to be sloppy with the medications that you choose and how you choose to use them. OCD deserves a structured, evidence-based treatment along with evidence-based psychotherapy as well. So start by maxing out the serotonin reuptake inhibitor, hold it for 12 weeks, and avoid shortcuts. Don't try to augment prematurely, don't try to do things too quickly, and really educate your patients about that as well. That this is not a short process. This is going to require some work on your part, and you may not feel better right away. It may take some time before you truly have that improvement. So I think what we need to do for patients is advocate for proper dosing, and for providers, we need to go back to the basics and get them right. Have you guys seen OCD mistreated like this before? I know I have in several occasions, which is why I made this video to begin with. And if you've seen similar things or even different things with OCD treatment, drop a comment in the comments section below. Let me know what you think. Let me know your experience with either being treated for OCD or treating OCD. And if you found this video helpful in any way, again, I am Dr. Garrett Rossi. I am representing Shrinks and Sneakers, and I would love to make you a subscriber to this channel. I would love to hear your comments, hear more about your struggles or your successes with psychiatric treatment. So we've got more real cases coming your way in the next video. Thanks again for watching.